Good afternoon, Dr. Rosenthal.
Hey, how's it going? Can you hear me?
Yes, we can.
Perfect.
We normally have everybody kind of rapidly jump on in the first 2 minutes. So we'll give them just another minute or two to get logged on.
Maybe, can you give me the share screen so I can try to figure that out? Or do I just start sharing?
Yeah, you can go ahead and pull it up if you want, and we can go ahead and check that part. Do you see the button at the bottom?
Let's see if I can figure this out. Does that work?
Yes, perfect.
Perfect. Just tell me when to start, or y'all, whatever works for you guys.
Okay, I think it's fine. We'll have more people join. I'll just kind of give everybody an introduction. Today we have Dr. Richard Rosenthal, who's a professor in the Division of Endocrinology. We've decided to start kind of a series of chalk talks that are pertinent to both the inpatient and outpatient setting and discuss some topics that bridge both areas. So we'll have Dr. Rosenthal talking about thyroid diseases today, and then we'll have a break when Dr. Turner and Dr. Alloway will do HIV and heart failure, and then we'll follow it up with subsequent talks following that. So with that being said, Dr. Rosenthal, I'll let you take it over.
Oh, perfect. I appreciate it. I had sort of thought about this and mentioned it to Kirsten, and I met with Dr. Peters and just sort of thought of a way to try to connect some of the ambulatory people with the hospital medicine people. I think this place is so huge. You know, maybe some of y'all that are in hospital medicine may have rotated through endocrine clinic in the past, but I'm hoping this thing is sort of well received, and we can get a couple of different topics to help transition some of the patients from your arena into our arena, answer some questions, and then, you know, also try to get us to bond a little bit better, maybe do a couple little things outside of hours where we can sort of meet each other and learn some of our skills and so forth. So with that said, we'll go ahead and start. This is a little presentation I put together and sort of edited a little bit, but during the pandemic, when we started getting a lot of consults on stuff, patient couldn't get in and so forth. So you'll sort of see the theme of it as we sort of move through. My only disclosure is I was on an advisory board last year talking about thyroid eye disease and Tepezza. I don't think it has anything to necessarily do with this talk. So the first case is a 50-year-old white female presents for a TER visit. Y'all know TER is telehealth. Recently discovered thyroid nodule, no previous history of thyroid disease on exam. There's you visualize a 4-centimeter mobile nodule, right lobe, doesn't move. How do you work this up basically? You know, the first thing, and here's sort of the answers, and the first thing you always want to think about with a thyroid nodule, whether y'all get it on an incidental finding from another imaging test, is to get the TSH. So even something as small as that can facilitate things a little faster in the outpatient world, or if the radiologist would do ultrasounds while your patients are there, you can get it done a lot quicker. So you order a serum thyrotropin level, which is a TSH level. You don't need any of these other tests. You're trying to save healthcare dollars, just order the TSH. How about if the TSH comes back suppressed? What's the next step to do? The next step to do would be to get a scan and an uptake. Again, sometimes y'all can get that done with nuclear medicine. If they're in the hospital, you get the order in quick enough. If you got a scan or an uptake, a suppressed TSH, and the scan shows that the nodule is hot or hyperfunctioning like a toxic adenoma, it's a lot less likely that it's going to need any kind of biopsy, because about 99% of those nodules are benign on biopsy. So we usually don't even biopsy it. And if you have a hot nodule, the treatment of choice is to either take it out or go ahead and ablate it. If y'all roll over to the 7th floor and ever want to look at a scan, or you're taking board tests, This is what a hyperfunctioning nodule looks like on scan. That right lower lobe, a little hyperintensity there, suggesting that the thyroid's producing a little bit more thyroid hormone. We talked a little bit about biopsies. When do we biopsy? We know these are done as outpatients. There's Bethesda classifications. When I see patients in the clinic, I basically tell them there's four ways that the nodule can come back. It can either be benign, that's about 90 to 95% of the time. It can be malignant, that's about 5 or 10% of the time. Indeterminate means you can't tell one way or the other on biopsy. 20 or 5 years ago when I was in training, we would send those to the OR and 20% would come back malignant, 80% would be benign. See, we were doing some unnecessary surgery. Now we get this Afirma testing on these lesions. We send it out for some additional molecular testing. And if it's Afirma positive, it suggests there's about a 40 to 50% chance of malignancy. If it's Afirma benign, then it puts it back down to a negative predictive value of about 5%. So again, even when we tell patients their nodule is benign, we're wrong sometimes. So we repeat these ultrasounds in 6 or 12 months to make sure they're not growing, that the volume of the nodule hasn't increased by 50% or it hadn't grown by 20% in 2 dimensions. The other potential result would be an insufficient biopsy, meaning they just didn't get enough cells. The TIRAD system is what the radiologists are using now. It's sort of off of that BIRADS from breast. Comes up with 5 numbers, 1 through 5, based on basically a grid talking, is it hypoechoic, anechoic, is it irregular, is it taller than wide, does it have microcalcifications, and it gives it a number to prove the likelihood that it's going to be benign or malignant. Actually, I was on a conference early this morning from Penn talking about this, or I was listening. I wasn't doing the conference, but I was listening, and I think the point to remember about TIRADS, and I've talked to the radiologist and I've talked to some of the primary care doctors, just because the radiologist says you can follow it up in a year, don't always have to do it that way. It's just a suggestion. So you still have to put the clinical picture together: family history of thyroid cancer, history of childhood radiation, is it big, is it compressive? All those kind of things are important, where just because it's a low TIRADS doesn't mean you don't have to biopsy it. Types of thyroid cancer, you probably remember that. Papillary and follicular, about 85 to 90%. Medullary is about 5%. Anaplastic is very rare. Actually, I saw one of these about a week ago, presented with a cord that was out, biopsied and, taken out by a private ENT in town and sent it over, and had a 2.4 anaplastic. We actually sent this guy out to MD Anderson, or he wanted to go out there, and they have a big clinic out there, and he was BRAF positive, and he's going to start TKI. So maybe he'll do okay, hopefully. Surgery, lobectomies versus total, up to the surgeon. I think there's a lot more of these surgeries being done on the lobe only. Radioactive iodine. I came out in training back in the 90s where we ablated everybody with tons of radioactive iodine. So I tend to still encourage at least 1 dose. I usually have to argue with the nuclear radiologist, but you can follow some of these a lot more conservatively with imaging and labs. Remember subclinical hyperthyroidism, the definition: normal free T4, normal total T4, normal free T3s and T3s with suppressed TSH. So in general, the definition is basically, if you see a patient like this and they're having all kinds of weight loss, heart racing, nervousness, shakiness, and their free T4 and free T3 are normal, it's unlikely that the thyroid's causing a lot of that. So don't get too looped in that it's all thyroid causing the symptom complex. Here's the causes. Again, your basic breakdown of things that could be causing the suppressed TSH. Always think about suppressed TSH from a little bit more thyroid hormone than they need. So sometimes you just need to back off. I back off by not confusing them by changing dose levels. I just tell them to skip a pill a week or skip a pill every other week. Here's another case: 28-year-old female, incidentally noted to have elevated thyroid antibodies or positive thyroid antibodies. I guess they're elevated. She was being evaluated for urticaria. Her mother has type 1 and Hashimoto's, and the glands about 30 grams. That's 1.5 times size normal. Glands 20. No nodules. TSH normal. What should you do with this patient? So she's got normal thyroid levels. You don't treat the antibodies with thyroid hormone replacement. You usually do not biopsy these, and I tend to repeat ultrasound. So if you catch an ultrasound from an outside facility and they're talking about a nodule and they're having Hashimoto's, it's probably a misread, or they're just not reading it correctly. This kind of heterogeneous look, almost like you would see on a giraffe kind of thing. Those don't really need biopsies. I think our radiologists are phenomenal here and do a great job and help us. So I like to repeat ultrasounds. You don't need to check more antibodies on this lady. I would just check her thyroid level annually, because there's a 1 to 2% chance of developing hypothyroidism each year. Subclinical hypo is the opposite of hyper, usually from Hashimoto's. Gland can be a little bit enlarged. These are sort of some of the patients that are at risk for hypothyroidism. If you have one autoimmune condition, you're a little bit more likely to have some other ones. I don't know how much consultation y'all get from the OBGYNs. They know this stuff, but lots of postpartum thyroid dysfunction, and we'll go over a few cases like that later. Patients with Downs and Turner's also are more likely to have thyroid disease, previous head and neck surgery, radiation as well. TSH levels, a lot of times they can be a little higher in white populations is a thing to remember. Sometimes we'll have patients that have come in and they're begging you to get their TSH from 4 to 3, and they think it's going to make them lose 35 pounds. That just doesn't happen. I saw one of these kind of patients yesterday that was just basically demanding me to keep her TSH between 0.5 and 1.0. And I just had to tell her that, I respected her, obviously, but we want to make sure there's not other things going on. A lot of times, especially in the ambulatory world, everybody wants to tie everything into the thyroid. The other thing that's very common is that as patients age and get into their 7th and 8th decade of life, sometimes that TSH will trend up a little bit. There's changes in the axis as people age. So if you have a patient in their 80s or their 90s and their TSH is 6 or 7, I tend to leave them there, especially if they're free T4s in the normal to mid-range of mid-range. Higher and heavier patients or patients that carry a little extra weight through the effects of leptin on TRH may have a higher TSH value. Y'all all know the signs and symptoms of hypothyroidism. There's a whole slew of them. I rely very heavily on the TSH. You can just imagine a patient's coming into a new consult. They fired 4 or 5 of their other endocrinologists, and they come in and they're tired. They've gained weight. They're cold. They're constipated. They have no energy. Their TSH is 3, and they say they have hypothyroidism. That probably our lab is broken, and that's why we can't pick it up. But I tend to rely real heavily on the TSH. Again, I'm empathetic. I don't want them to not feel that we're listening, but we don't want them to go down a pathway of hypothyroidism when it's really not. Again, some bullet points on Hashimoto's. I think, again, y'all are familiar with what most of these are, mainly in women. But we do see a lot of men that have thyroid dysfunction, and they can have antibody attacks. When we replace thyroid hormone for someone who's had their thyroid gland completely removed, the number that I was taught in fellowship here was, 1.6 mics per kilo. If you have a patient that tends to be a little bit thinner, their requirements may be a little bit higher. You could shoot more 1.8. And on the flip side, of the BMI is greater than 25, 1.3. But I think a good solid number to start is 1.6. We don't stop proton pump inhibitors. They do affect gastric pH and may affect a little bit of the release of thyroid hormone, but not a ton to make the levels a lot different. They may have a little higher requirement than somebody that's not on them. These are just little angles to think about. I mean, again, y'all are in your world, you're not ordering TSHs at certain times of the day. But if you're struggling trying to figure it out, you know, you might want to get a fasting TSH on somebody, you know, in the morning. This is a case of a 50-year-old that we did a telehealth on the phone. Been taking Synthroid 150 for the last 10 years for the treatment of hypothyroidism. At his annual visit, you get blood work, T4 normal, free T4, excuse me, TSH a little bit up, no change in any of his medication. And over the last 15 years, whenever you see him, he's always normal. So what do you think happened here? Do you think he developed a macroadenoma in the pituitary? That would be doubtful. Does he have pituitary resistance to thyroid hormone? Again, that sort of presents with high free T4s, high TSHs. You know, that again, he's been normal before, so that'd be unlikely. No, nothing in the stem says he was on dye. I'm hoping 50 is not old, but it feels it sometimes into your 50s. But this gentleman is what we see commonly happens in the clinic. You know, he forgot, he ran out, he got the reminder call, and he decided to restart. It just takes a lot longer for the TSH to catch up than the free T4. So whenever we make dose adjustments, we recheck thyroid levels 6 weeks later. And I've always wondered when I used to do endocrine consults over there, you know, there's no real reason to kind of be repeating thyroid levels all the time. I mean, if you're making a dose adjustment, you're going from 100 to 125, and you got a patient that's going to be on your service for 10 days, and you're turning it over to the next colleague, somebody doesn't need to come in and just recheck thyroid levels. I mean, it's just unnecessary. So try to think about that sort of 6 to 8 weeks for the pituitary thyroid axis to re-equilibrate. Best time of the day, this may help you on some of your discharge instructions. This was a study that was done in the JCEM, you know, about 15 years ago. And the long and short of it is they found that the best time to take it is 30 minutes, probably more like 60 minutes prior to eating or drinking anything in the morning. So if you're having a patient that's struggling with absorption, you may want to go in that route. Some of the non-compliant patients that we take care of here, we just want to get them in it once a day. A couple other little tricks. If you forget it one day, maybe take 2 the next day is fine. I think the other thing too that's very important is asking their compliance. And I think I figured out how to determine if a patient really is taking their thyroid medicine. So you ask them, you know, Ms. Jones, are you taking your thyroid medicine? Yeah, I'm taking it. Okay, and then about a minute or 2 later, you say, you know, in the last 30 days, how many pills do you think you might have skipped or missed? And it's always different. So that's a little angle I've tried to kind of trick them on a little bit to really know, because it's helpful when the values come back and they're a little bit off. If they've missed it for 5 days in the last month and the TSH is 12 or 14, you don't need to increase their dose. If it is mildly elevated, the other important thing to do is to make dose increments of, you know, maybe 25 to 50 micrograms. Don't do what I get a lot of consults on. Patient goes in to see their primary care doctor in the community. Their TSH is 4. For some reason, they start them on like full replacement of 100, and then they come back in a month later and now it's 4.2, and then they double the dose more. And those patients can get in trouble and develop, you know, osteopenia. They can develop arrhythmias and things like this. We get lots of thyroid consults here. This is a colleague calls up, and he's not talking about his neighbor. He's talking about his neighbor's coworker that you've got to figure out for him. Got alopecia, comes to the clinic for an opinion on thyroid levels. Which set would lead you to ordering an MRI? So alopecia, abnormal thyroid levels. I think A's pretty stone cold normal. C looks like maybe more like primary hypo, you know, 3 T4 low, TSH up. This one here looks more like 3 T4 normal, TSH suppressed. You know, maybe they're mildly hyperthyroid. This one right here, free T4 normal, TSH, you know, normal TSH with a high free T4, it makes you sort of think about, you know, secondary causes, and we'll talk about that a little bit later. But this is one that just a prime kind of a number. Low free T4, low TSH makes you want to think about something centrally going on. So you may want to order, an MRI of the pituitary. You could get away for one of these potentially, maybe a TSH-OMA or something like that, but low free T4, low TSH, think about centrally. The other little trick that I was taught back in the day is that if you have a postmenopausal woman and you're trying to figure out TFTs and you're thinking centrally, maybe order an FSH, because if an FSH is low, below 1 or single digits in a postmenopausal woman, that makes you think about something centrally, because obviously the FSH should be very high in that person. Lots of drug effects. Great article here if you want to read on your, some free time or whatever. Drug effects on the thyroid. This was in the New England Journal. This is like one of these kind of thyroid gurus nationally that wrote an awesome article, and there's lots of great information about all the differentials here that, if you want to, educate some of the residents that might work with your nurse practitioners, anybody that, is taking care of patients. This is a great reference article that you may want to pull. Lots of drugs can affect thyroid levels. Heparin is one that you should be concerned about. It can cause a high free T4 with a normal TSH. These Caesar drugs will cause low free T4s with normal TSHs. Biotin is a classic effect. We try to get patients to come off of biotin for, a few days prior to thyroid levels. So if you ever get one of those kind of values that comes back with a high free T4 and normal TSH, think about a biotin effect, or they've been hanging out at a GNC store, things like that. And obviously amiodarone causes lots of abnormalities in the thyroid. Remember, amiodarone has a very high content of iodine. That's about 35 times the normal daily dose needed. Postpartum patients also present with thyroid abnormalities. This particular person comes in for a video visit with an elevated free T4, a TSH that's low. She's lost some weight to pre-pregnancy weight, having some palpitations and tremulousness, and you repeat levels and they're essentially the same, high free T4, low TSH. What would you do here? So she's 6 months out. Remember, is that when patients develop postpartum thyroid dysfunction, they can get hyperthyroidism, they can get hypothyroidism, they can get hyper, go normal, come on back and to low and then get normal. They can get hyper and become normal. They can get hypo and become normal. So there's 5 or so different kind of curves they can fall on in the first, 6, 9, 12 months. So early on, I would not start anti-thyroid medications. You don't want to send this person for surgery. You could get a thyroid scan and an uptake. Remember, if you have a thyroiditis, there's not going to be a lot of uptake on the scan and your number's going to be low. If this particular person had Graves or toxic multinodular goiter, then your uptake's going to be high. You're going to see it on the scan. So I'd be very careful with thinking about anti-thyroid medications, and probably, if you're worried about it and they got some symptoms, just a beta blocker and probably follow them up a little bit closer than a year, but, making sure they're following up with a primary care doctor or one of us. Lots of effects of pregnancy on the thyroid. Iodine requirements are increased. Serum free T4 decreases a little bit. We tend to keep that total T4 in the upper range of normal by a factor of 1.5. And as you know, whenever you see a total T4 that's high, think about TBG being increased, like with birth control pills or pregnancy. And that's probably one of the easier consults we get, is usually from the community. The patient went in, they checked the total T4 and a TSH, and the total T4 comes back 20, upper normal is 12, TSH is normal. They think they're hyperthyroid, but it's strictly an estrogen effect from the birth control pill. So again, postpartum thyroid disease is an autoimmune disease. Resolution usually occurs in most of these patients, and their hyper and hypothyroidism tend to be transient. And a key thing to remember is they don't have thyroid pain. And that's sort of a differentiating thing between that as well as compared to other forms of thyroiditis. Here's the next case of a 28-year-old female who had a total in her 20s for Graves on Synthroid or levothyroxine, normal TSH at her initial visit. She's 6 weeks pregnant, taking an OTC prenatal vitamin. What is correct? We always tell patients to let us know if they become pregnant. Actually, I saw one yesterday and saw them. She's like 8 weeks, and we did all this. You know, we increased her by 30%, which is what you're supposed to do. The easiest thing to do is if they're on 101 a day, whatever the dose they're on, just tell them to take an extra pill twice a week. That goes up by about 30%. Remember these type K questions. So if one's right, three's right. So you always check TRAB levels at the end of the second trimester because of potential neonatal thyrotoxicosis. Actually, I saw an awful case about 6 months ago of a lady who had Graves and passed the TRABs through the placenta, and the baby passed at 5 days from neonatal thyrotoxicosis and had thyroid orbitopathy and everything. It was horrible. So these things unfortunately do happen. Getting these patients to maternal fetal medicine doctors are key. Remember, the thyroid gland forms at about 11 or 12 weeks. So you don't want to wait there. You want to go ahead and get these people started quick. The answer here is A, because people who are pregnant waste iodine. Only about 30% of the prenatal vitamins contain iodine. So you want to make sure that their prenatal vitamin contains iodine because they tend to waste it in their pregnancy. But what was interesting about this lady I saw yesterday is her mom was with her, and when I walked out of the room, you know, we're going to check them back in a month. She looked at me, she goes, "I'm so mad at you. My daughter called you to tell you she was pregnant before she called me." So, you know, since she was a good listener, I didn't tell her she had to call me right away, but I usually tell them to let me know in a couple of days so we can check their levels and adjust them. Here's another Hashimoto sends a portal message. We hang out in the portal all day long with these messages, and this lady wanted to talk about her levels. She's 14 months postpartum. She's breastfeeding on no medicines. She's gotten back down to her pre-pregnancy weight, so she's 14 months out. She goes to a book club meeting back in the day when these were masked, and she was talking about her dry skin, her nails, her hair was all over the drain. You get her thyroid levels, and this is what they look like. Her free T4 is 3, which is high. TSH is normal. No evidence of thyroid eye disease. Her gland's normal. Do you scan her because she's got postpartum? Well, she's 14 months out, probably too late. Do you want to start her on anti-thyroid medications? Usually you don't start anti-thyroid unless the TSHs are completely suppressed. No real reason to get an ultrasound or get TSI, but when you look at this lady, somebody in there started suggesting that they take biotin. Biotin affects the thyroid hormone in one of two ways, either through this sandwich assay where the thyrotropin level tends to be a little low, or through the other one is called I forgot this, a different type of an assay. I'm missing my thought process here. Sandwich or competitive assay, I think. On the other assay, the free T4 levels tend to be high. So one of the first questions you should always think about when you see an elevated free T4 is, are they taking biotin? A lot of the supplements, multivitamins, things like that can cause that. This was the other one, competitive assay. So the excess biotin causes a low signal being yielded at this sort of binding site, and you get a falsely elevated free T4. What I have found here at UAB is that we don't really see the low TSHs from the biotin. We see the high free T4s from the biotin, the way ours works. How about neck discomfort? This patient developed a painful thyroid gland 2 weeks ago. She states prior to the neck pain, she had COVID and had minimal symptoms in quarantine. Her gland was boggy, couldn't really touch it. So these people jump when you touch their thyroid. She's got labs consistent with hyperthyroidism, and this is subacute thyroiditis It could be a hemorrhagic cyst, but after a viral infection, usually about 6 weeks later, if people are going to get subacute thyroiditis, it's painful. A lot of times these patients present to their ENT with referred pain to the ear. STED rates tend to be a little bit high. Usually we treat these with beta blockers and non-steroidals, but I've had some that I just go ahead and put on a dose pack. Sometimes they need 2 dose packs, but they do not feel well, and I would not be too hesitant about using a dose pack. Thought to be viral in nature, viral prodrome, and again, it's self-limited. It can recur though. Usually they'll return to a biochemical use thyroid state. However, they can have recurrent episodes of this. So definitely they'll call you back if they get that again. We've seen a lot of COVID related thyroid issues in clinic, and it's just basically the classic kind of symptom complex. I think as y'all know, probably better than me, is that, sometimes the COVID is a lot, is more self-limited. So where they might not have had typical symptoms of COVID, maybe the symptom they developed was, a subacute, thyroiditis. I don't know if y'all get called on the missed line for consultations. We do. You're contacted by a provider in this situation, and they're talking about a 72-year-old who had just started an immune checkpoint inhibitor or a combination treatment of ipilimumab and nivolumab for malignancy, and developed these abnormal thyroid levels. Had lost a few pounds, fatigue and heart racing, put them on a beta blocker. And so what should you tell this person on the recorded line? Do you tell them to stop the immune checkpoint inhibitor? Do you tell them to start anti-thyroid medications? Do you refer them to the access center for the next available appointment? We know that's hard to do. Do you tell the referring doctor to check them back in 3 months? None of these are right. The middle one is correct. And the thing that's interesting about this, and I'll show you as we go through the slides, is unlike other forms of thyroiditis that kind of change gears and go from high to low, they develop the hypothyroid phase very quickly. So when you see the levels that are looking like this, you really need to recheck the levels in a couple of weeks as opposed to 6 weeks. Immunotherapy has been great for lots of cancer treatment, but it does come with autoimmunity issues, including thyroid hypophysitis. A lot of times you need to think about doing cord stem test on these patients to make sure they don't have a secondary adrenal insufficiency. And there have been some cases of autoimmune pancreatitis leading to type 1 diabetes and failure along those lines. They basically leverage the immune system to kind of release the brakes. It's a destruction of the thyroid gland, likely cell-mediated, limited role for antibodies, but it has been suggested that when you have these patients who have these problems with checkpoint inhibitors, that if they develop this thyroid abnormality, it tends to show that they're doing a lot better from their cancer perspective. Initially a thyroiditis, hyperthyroid phase, hypothyroid phase, usually permanent. And again, looking at the total T4 levels, you don't wait too long. I mean, this is the TSH already low. You're getting them started a lot quicker than you would with other forms of thyroid dysfunction. So again, it's reassurance on the hyperthyroid state. You might want to do a little bit of beta blocker, but remember, you got to titrate them off that beta blocker because they're going to get into the hypothyroid phase very quickly. No real need for steroids, no need to stop the immunotherapy. And as I talked about before, some of these side effects suggest survival benefits of treatment. So last few slides, and then I'll open up for a few questions. I was unsure if y'all I didn't know if y'all only met for an hour because I thought you had a meeting as well. But my goal was to try to do these things in 35 or 40 minutes. This is some of the telehealth tips that we try to think about is, making sure your patients have primary care providers, always important. if they've seen an endocrinologist in the past, a lot of times that's very helpful because you're not starting with kind of a new problem and you can maybe get old records or know the endocrinologist they were seeing. I always try to find out about thyroid is like why they started it. A lot of times patients start thyroid medication inappropriately. They go in, they've gone to an alternative health clinic, they've given somebody $1,500 in cash. They're putting them on Armour thyroid. They're putting them on thyroid medicine when their TSH is normal. Again, ensuring that they're compliant with the medication. Thinking about name brand versus generic. I tend to prefer name brand if they can afford it. It's usually not a ton more and it's more consistent from dose to dose. Seeing if they're filling the medications. The big absorption issues we see with thyroid are calcium and iron, so separate that for 4 hours. Biotin, we touched on that. Hoarseness, trouble swallowing makes you think about compression. As opposed to doing ultrasounds on these people, you may more to go down the route of CAT scans of the neck and making sure you're not impinging on the trachea or the esophagus. Having radioactive iodine in the past, understanding that. Did they have that? Do they have a scar on their neck? Has it been removed? Supplements always affect thyroid levels, ashwagandha. If it's a supplement, a lot of it can really affect it. The biotin are the big factors. I don't really use combination therapy. There was an old study, in the New England Journal 20 years ago that took people who were on Synthroid 50 or 75 and dropped them to 50 and added in a little Cytomel, which is T3, and saw that they felt a little bit better. And then that study was refuted 9 more times. So it was proven okay in one study and it was proven wrong in 9 other ones. So I'm not a big fan of that. If your patient walks in with this shirt on or has a book, you're probably going to be in for a long clinic visit. Lots of books out there, Facebook pages that I'm not saying they're bad. I mean, I think groups are good and they're very important for patients, but sometimes there can be some false information that they get. A little note from one of my kids when I was putting this together to always ask about those book club minutes and making sure that the prenatals contain iodine. So I'll stop there, take some questions, and hopefully this was something that maybe we can keep going with some other topics from other subspecialists to kind of give y'all a perspective of the outpatient world.
I think that was a really nice summary. I mean, these are some things, I mean, we come across them, but not often for any individual person. So I think this is a nice summary. I know you mentioned like when we find these incidental thyroid nodules about checking a TSH, that's helpful for transitions. Are there other opportunities that you see from the hospitalist to the outpatient world? Any other areas where you think, we can?
Yeah, I mean, I think the other key point to speed it up for the patient is sometimes going ahead and setting up that ultrasound for them, especially if they're in the UAB system and they have a primary care doctor, or, if you saw an incidental thyroid nodule on a CAT scan or a pulmonary angiogram, and you just say, follow up with your primary doctor, the primary doctor is going to get the thyroid ultrasound pretty much anyway. So go ahead and maybe set that up as an outpatient, or, there's so many places to get these, with Hoover and Gardendale and Leeds, and that speeds it up. And I don't think it's necessarily always from the hospital group, but I hate the patients that are out in a rural health clinic and somebody found a 3 millimeter cyst and they tell them they need to go see a thyroid specialist, and they may take their thyroid out and they wait 6 months for the visit. So, being confident on some of these sort of simple, primary care kind of ambulatory things may help as well. Do y'all call a lot of the endocrine consultations in the hospital, or do y'all kind of run the show yourself?
I think it's kind of a mixed picture. I mean, I think when they're grossly abnormal, everybody's going to call endocrine to come and help.
Yeah. And I think the other thing that's important, and again, I'm a big fan of, is if you see somebody that's like really sick, you know, it's got really floor and graves. I mean, page me, you know, or I'm not, you know, or vocera me or email me or just say, you know, get them the appointment, say, hey, they're scheduled in 2 months, and then send me an email. Can you get them in sooner? And we can always add them on. I mean, it's not a problem, especially those kind. I mean, we don't really love to add on the one that's fired 5 or 6 endocrinologists, but you know, the ones that are brand new, that got something going on, at least me, that's the way I roll. I mean, feel free to call me, and Andy Allen over in the what is he over there in the, what's that place called, the acute care center, urgent care center. He was actually, when I was a acting intern back in the day, he was like a 3rd-year resident, and you know, he's like the Harrison's internal medicine book. He's so thorough with everything. When he calls, I don't even ask questions. I just sort of add him on, and I'm sure y'all have a lot of colleagues that have that talent like him. So we're here to help is my point. I think the other point that I mentioned to Tim as well as to Kirsten is that what I've seen from being here for almost 25 years is that the way medicine has changed, and I mentioned this to Tim when we had breakfast a couple months ago, is that we don't know each other as much. I don't think it's all pandemic, but hospital medicine is a new thing that's come out differently. And I think we need that kind of communication and knowing who people are. But just looking at the names on here, you know, if I ran into one of y'all at the fish market, I wouldn't know you. I mean, 20 years ago, we knew everybody. So I think that'd be good. And if you think, if you like this, you don't have to like it, by the way. This is a suggestion, but if you do think it's good for us to pop in and do something like this, just send me an email, the topic you like, and I'll find an ambulatory person. Because I don't think because I think the ambulatory world, what we do is different than if you're doing an endocrine consult sometime. I'll stop talking.
This was great, Rich. We really appreciate you coming and speaking to our group, and are more than happy to return the favor if you think that could be a benefit to some of the ambulatory folks.
Yeah, I think as we start, you know, with some of the things that Dr. Kennedy's trying to do, I think as we start and get some more in-person meetings and things like that, I mean, having a hospitalist to come over and sort of give a, you know, 20 or 30-minute blurb on a topic that, you know, like you said, a reciprocal type thing may be interesting.
Yeah, agreed.
All right, well, I'll sign off, let y'all start on your other meeting, and thanks again for letting me invite myself and do this. I enjoyed it.
Thank you.
Thank you for your time.